procedure that was shown in the simulation. And as you can see here, the trainee is being shown how to get the right position to do the right minimal surgical procedure, minimal access surgery procedure, which is, in this particular case, removing a stone from the common bile duct of the patient. And as you can see here, teamwork is very essential in this surgical procedure. It's not one-man band, and that's why a team simulation practice is so important to create the environment that you'll face in real life. So you can see it's successfully retrieving the stone out. And he's putting the stent in as if he was doing the simulation exercise, but now in the real life situation. So it's no longer C1, do one, teach one. It's C1, do 10 times on the simulator and do it on the patient. So mastering competence is important. So credentialing in MAS is what we have practiced in Hong Kong for the last 10 years. In particular, for the surgeons in Hong Kong, we have a 2-day course on basic and advanced laparoscopic surgery skill. This is supervised by Hospital Authority and the College of Surgeons of Hong Kong. And this is a structured program to ensure competency. The program involves lectures, live surgery demonstration of particular basic and advanced laparoscopic operation, and the use of simulators. And you can see here, this is a laparoscopic simulator where the surgeon is practicing specific procedure of dissection. And this is a virtual reality, but with tactile feedback, because you're actually working on live animated tissue, not a computer tissue. And this is, of course, in our lab, where the surgeon are taught how to use a flexible endoscope to do a procedure of EST. And this is all new skills that's currently available to treat our patient. But they don't need to do this on the patient on a first-come, first-served basis, but they can practice on these training modules before they practice on the patient. And of course, nothing more than the real thing is to do the real operation, but then they are being assisted and performed under supervision. They should go, and they also go through objective image-based assessment, because when they operate in the OR as an independent assessor, we can see them in the conference room and actually observe the operation. And this practice, we have used it, proctoring practice, have extended even to overseas. For our home hospital, Hong Kong Hospital Authority, their objective and independent assessment of the competency by record of the training. On the individual level would be the training record. On the team level, their performance review of their operative complication, infection rate, complaints, readmission rate, length of stay, morbidity and mortality for the individual operation. And the department level, it will benchmark against the other HA hospital and international standards. Finally, I want to just touch on robotic surgery, because everybody thinks robotic surgery is some amazing surgery that's only done by very expensive equipment. But in fact, robotic surgery is a very expensive equipment currently, but what it does is minimal access surgery, because it's equivalent to laparoscopic surgery. But its ability to overcome the disadvantage of conventional laparoscopic surgery allow us to do more refined and more precise dissection for extraordinary surgery, example, cancer surgery and function preservation surgery. But again, robotic surgery needs training, needs simulated training before we cannot just go and look at how this operation is being done by the machine and operate on the patient. I would never like to see that happen, because that is using the patient as practice target. We have acquired this machine for 2 years now, and we practice on over 200 patients, but not practice, we operate on 200 patients. But when the machine was first introduced to the hospital, we did not use it on the patient straight away. We practiced for 6 months on animated tissue, but in OT setting, so that we get our skills together of learning the exact ability of the robot before we move on to the first patient operation. But now there are some virtual reality simulator recently been available for surgeons to practice on this simulated model. Now, this is called Da Vinci Skill Simulator, to allow the surgeon to put their hands, operate as if they were with a live suit patient, but on a computer virtual reality program. So I think, in conclusion, ladies and gentlemen, simulation training and competency-based curricula offer an opportunity to improve current training models, to address the challenges and create effective, efficient, and safe residency surgical program for our future generation. I thank you very much for your attention.
Dr. Lee. Hello, Dr. Lee, Yuedong. Thank you very much, Yuedong from Mayo Clinic, Rochester, Minnesota. You talk a lot about the education training for the residency. Do you see the value of the simulation and for the current practice surgeons to doing the warm-up or rehearsal for the difficult cases in the future when the development is of technology?
Absolutely right. But when you talk about training, you start from the basic level. And what's currently lacking worldwide is most people think laparoscopic surgery training is advanced level. It's not. Laparoscopic surgery, the difference between laparoscopic surgery and open surgery is that you don't have to open somebody's abdomen up to do the surgery. You reduce the trauma. What you do inside is exactly the same. But before, when laparoscopic surgery was introduced, people do it as an advanced procedure, like taking an appendix out, taking a cholecystic gallbladder out. And you only reserved it for somebody who completed specialist training. They go on a laparoscopic surgery fellowship. This is not the way to go. MIS skills is one of the surgical skills we have, just like with a scalpel, except that we have to learn to apply it to the right disease process for the benefit of our patient. So we should start from the residency program. When they finish their residency, they already skills at this. If they want to do more complex procedure, they go into a subspecialization, whichever specialty they prefer, hepatobiliary, colorectal. But they should not do it when they become a specialist. They should do it, they should learn and do it well before become a specialist.
Thank you, Prof. Lee. I'm Suk Wei from Singapore General Hospital. It's remarkable and admirable how you run your program. And two questions. Number one, your residency certification and training program, is it a national program and it's part of their assessment and progression onto the next stage? And number two, I noticed that, but for sure, I mean, a lot of the skills that you're trying to train, it's like individual skill, although there's one nurse, so it's a limited team play. Is there any a vision to put this into a wider teamwork?
To answer your first question, we're very lucky. Hong Kong has managed to recognize the need for training for these MIS skills. So back in 1995, when I started our training center, we've been teaching on our own drive of this new technique in surgery. But in fact, for the last 10 years, it's been now formally sanctioned by the Health Authority and the College of Surgeons of Hong Kong for doing this program. So the certification and competency certification goes to the individual surgeon, trainee surgeon, with a formal certificate of competency and attendance from Health Authority here and the College of Surgeons here. So that's very important. So the trainee would, in a way, require to have this before they go for their exit exam in residency program. So they all, now 100% of our trainees have to commit to this program. As to the second question, I've always believed training is not just doctors. Training is teamwork. It's really, a lot of our surgery nowadays is not just one surgeon operation. In fact, I think most surgeries are done by two surgeons. Gone are the days when the surgeon comes out and says, oh, I've done 8 hours of Whipple's operation by myself. That's only satisfies his ego. Doesn't do any benefit for the patient, because you'll be too tired to declare competency after 4 hours of surgery. Why do 8 hours? So we should do it as a team of 2 specialist surgeons or more to do very complex procedure. And in particular for minimal access surgery, best demonstration of teamwork. The nurses got to know the equipment, the surgeon got to know the equipment, they got to operate together. And my last talk, robotic surgery. Nobody does robotic surgery by themselves. It's a master-slave model. You operate by the console, but you still got the team sitting next to the patient by the bedside, putting the right instrument in, helping to clip the right blood vessel. So if they don't work, you don't work as a team, you cannot do this surgery. It's not a one-man band. So yes, we do training for nurses, and you see the simulated OR in my training center. That's the whole reason. We can train 20, 30 nurses in our program for one particular module of operating theater. So they don't have to be 20, 30 nurses in our OT. But in the simulated training center, we do exactly what we do in OT. The patient setup, equipment setup, troubleshooting. When things goes wrong, what's wrong? Just like the real model.